breast conditions, including squamous fibrosis and sclerosing adenosis. A little bit about gynecomastia and male breast cancer, the lactating breast and common conditions in lactation, and then a few slides about pregnancy-associated breast cancer. So fat necrosis can mimic malignancy. It often presents as a tender or non-tender palpable mass. It can be the result of breast surgery, infection, trauma or radiation. Interestingly, there's no history of trauma in 35 to 50% of cases. It's commonly seen in reduction abdominoplasty, particularly in women that are overweight. So the case that's showing now is a 60-year-old female that had bilateral breast reduction surgery. She had quite extensive asymmetric fat necrosis in her left breast, but following surgery she had infection in her left breast with multiple drainages. So the management of fat necrosis is really based on the imaging features. Typically benign imaging features do not require any further workup, but suspicious features such as irregular masses, suspicious calcification, and architectural distortion do require image-guided biopsy. So this is the magnification view of the patient that I just showed previously. And you can see here, which is quite extensive dystrophic calcification. So in itself, it doesn't actually have any suspicious features, and you can see it's surrounding lucent fat necrosis. We did end up biopsying this patient, however, because she kept developing this region of density, and she had a very strong family history of breast cancer. So we didn't actually biopsy the calcification, but over time we biopsied this area up here, which was just fat necrosis. So these are the mammogram findings of fat necrosis. This one here shows the benign dystrophic calcification. It was a very benign appearance. Oil cysts, which I'm sure you've all seen, central lucent with thin peripheral calcification. They also have a typically benign appearance. This is a case of small masses with some central calcification. These are a little bit more indeterminate to suspicious. And then when you can get into coarse heterogeneous or even branching pleomorphic microcalcification, those are the ones that tend to need biopsy. On ultrasound, there's a typical progression of fat necrosis. In the acute stage, shown here, there's increased epigenicity due to edema, and this has a typically benign appearance and doesn't require any biopsy. These two are showing the more subacute phase. It's ill-defined, a complex lesion with some low-level internal echoes. This can sort of mimic more of a malignant process, and quite often these get biopsy. In the late phase, 1.5 years later, you tend to find that it has an echogenic rim with shadowing, and this again has the benign appearance. So it's really that subacute phase that can be a little bit more concerning. These are all images of fat necrosis. So this one's very cystic. It's pretty much developed completely into an oil cyst at this stage. This one here is a bit more of an irregular mass. Again, it appears indeterminate. You would probably biopsy that. And these two are a little bit more benign. One of the differentials for that subacute phase of fat necrosis is an intracystic papillary carcinoma. These are all intracystic papillary carcinomas. They're all that mixed solid and cystic lesions with some solid components. Can look a little bit like subacute fat necrosis. This one here even has some central calcification within it. So this is why it's really important to correlate with fat necrosis with your mammography findings, so you can check that it has a lucent fat centre. None of these would have a lucent fat centre on the mammogram. And also you have to be aware of people who actually present with trauma. This was a case that we had recently, where a 64-year-old woman presented with a very good history of her dog jumping up onto her chest wall. She had a bit of redness on her chest wall. Initially, we were thinking possibly this is fat necrosis. You can see it's this sort of mixed solid and cystic, has a bit of an epigenic wound to it. But this was actually triple negative breast cancer, and you can see it doesn't have a nice rounded wall, and there was actually a little bit of an area near to it, which was a satellite lesion. But the superficial nature of it and the history that the patient gave could have been quite confusing. So just be aware, sometimes people present with breast cancer and they say they had trauma, but in actuality the trauma has led them to feel the area and notice a couple of lump that was already there. This is another outcome of fat necrosis. So this patient had a wide local excision. This is just an oil cyst and how the calcification developed peripherally over time. Very benign appearance. This is a different case of fat necrosis, whereas this patient actually developed local recurrence at the margin of the fat necrosis. So just be aware to look carefully if you do see fat necrosis and there's a history of a wide local excision, because you can get a recurrence. This one actually had some nipple retraction involved. So the next condition we're going to talk about are proliferative breast conditions. These are important because they actually infer an increased risk of malignancy despite being inherently benign. So if you biopsy a proliferative breast lesion without any atypical features, it will have a 1.3 to 1.9 relative risk of breast cancer. And then depending on any atypical findings, these all have an increased relative risk of malignancy, going from atypical hyperplasia through atypical ductal hyperplasia, atypical lobular hyperplasia, from 4 to 13 times relative risk of malignancy. So this is the first proliferative breast condition. It's a 45-year-old who had a palpable lump in her right breast. I'll just give you a second to see if you can see it. It's not super easy to see. There's actually this lesion here in the superior breast, which is sitting here on the CC. It's got angular margins and it lies at the anterior margin of the glandular tissue. You can see it projecting out. This is what it looked like on ultrasound. It's very hypoechoic with posterior shadowing. Again, you can see it's at the anterior margin of the glandular tissue projecting forward. It's actually taller than wide, and it has that epigenic rim that we were discussing yesterday, which is often associated with malignancy or inflammation. It had some internal vascularity, and this is a case of stromal fibrosis. Stromal fibrosis is a localized area of fibrous tissue associated with hypoplastic mammary ducts and lobules. It's present in 2 to 9% of biopsy breast lesions. On mammography, it can have a varied appearance from coarse, impunctate or heterogeneous calcification, dystrophic calcification. It can present as a mass or asymmetry. On ultrasound, it's mostly seen as a hypoechoic mass or a mixed epigenicity mass. It can be well-defined or ill-defined. It often has posterior shadowing and there can be interspersed fat. So this case here is a 54-year-old woman who was reported from screening. This is a CCE magnification showing punctate and coarse heterogeneous calcifications in the regional distribution. That was biopsy-driven stromal fibrosis, and it was new from her mammogram 22 years ago. So as mentioned, stromal fibrosis can be seen in the setting of malignancy. It actually has a reported upgrade rate to malignancy 7% of the time. If you randomly sample dense breast tissue, it will often show stromal fibrosis. It does have an increased uptake on PET scans. This is one of the cases where it's very important to check that you have adequately sampled the lesion, as stromal fibrosis may be lying adjacent to malignancy. If you're thinking that there is ongoing concern, you really need to consider repeat biopsy. or short-term follow-up to ensure stability. That first case that I showed you, where it had that echogenic rim, we followed that closely for a few years. Surgical excision is recommended if the pathology is discordant from the radiological findings, or if it's a spiculated mass or fine linear calcification. This case is of a 17-year-old girl who presented with a palpable lump. You can see this very irregular, hypoechoic spiculated lesion with some associated distortion. She had very dense glandular tissue. This was biopsy-proven stromal fibrosis. And this down here was the case that I showed you earlier. And this was a case that showed up on the same day of invasive ductal cancer. And you can see the similarities between the two. This is definitely one of the lesions that needs biopsy and follow-up, if not surgical referral. And this is the next proliferative breast condition. This is a 40-year-old female with a palpable lump in her left breast. Pretty sure you can all see that. There's a small mass with slightly irregular margins in the upper outer quadrant of the left breast. And this is what it looked like on ultrasound. It's a hypoechoic lesion with some irregular margins. It's nearly taller than wide, extending through the tissue layers. It has at least indeterminate, if not suspicious, findings on both ultrasound and mammogram, and needed an ultrasound before biopsy. And this is a case of sclerosing adenosis. So adenosis itself is a benign proliferation of lobular glandular elements, and sclerosing adenosis is adenosis with intervening stromal fibrosis, which compresses and distorts the tissue. It's commonly seen in 45 to 55-year-olds. It's present in about a third of benign biopsies. If it's biopsy and there's an associated distortion, then it's known as a complex sclerosing lesion or a radial scar. There is 1.7 to 2.5 times the risk of developing breast cancer in a patient with sclerosing adenosis. Particularly, there's increased prevalence of atypical lobular hyperplasia within it and around it. On mammography, again, they can have varied appearance. They can have amorphous, pleomorphic or concave calcification. It can present as a mass with a circumscribed or irregular margin or an architectural distortion. On ultrasound, it can also have a lot of different appearances, a circumscribed mass with very low genicity, or it can mimic malignancy as an irregular mass with focal areas of shadowing. If a complex sclerosing lesion is found on pathology and there are concerning radiological lesions, we are still recommending excision. It's more of a benign appearance, such as a circumscribed mass, we tend to follow them up. This is a 32-year-old female with a lump in her right breast. We just have a look on that MRI and see if you can see it. It's not that easy to see. You might notice there's this little density seems superiorly in the breast. We couldn't see it on the CC mammogram, it was too far back. And this is what it looked like on the ultrasound. It was right up in the axillary tail. Small, hypoechoic, taller than wide lesion. It had quite a marked echogenic rim. And that was a case of sclerosing adenosis on biopsy. And this is a 55-year-old female. You can see that she actually had some calcifications in this area here. They're quite subtle. They were pleomorphic, and that was sclerosing adenosis again. This is a 45-year-old asymptomatic patient who presented for routine screening. And this is her mammogram and tomosynthesis. And you look carefully in here, there is an architectural distortion in here. Around there, it's quite subtle, not easily seen on the mammogram. There's no central mass, it just appears as a distortion. And this top row is what it looked like on ultrasound. There was an irregular distortion with posterior shadowing. Again, it appears to extend through tissue planes with quite suspicious appearance. It was indistinguishable from cancer. This had ultrasound by core biopsy, and then it went on to surgical excision. It was just sclerosing adenosis. And this is another varied appearance of sclerosing adenosis in a different patient. I've just had this irregular hypoechoic tissue with a few epigenicities in it. It was also quite hypervascular. Wasn't anything to see on mammogram, but it was palpable, and the patient said it was new. That was another case of sclerosing adenosis. These are also cases of sclerosing adenosis. This is a 31-year-old, smooth marginated mass, similar to a fibroadenoma or a phyllodes tumour. So this one was just followed up. It had quite benign features on ultrasound. And just below here, this is another biopsy-proven case of sclerosing adenosis in a breastfeeding patient. It's quite a bit larger, and it's isoechoic to the surrounding tissue. Now I'm just going to talk for a few minutes about a couple of other things: gynecomastia, the lactating breast, and pregnancy-associated breast cancer. So we did discuss gynecomastia briefly yesterday. It's benign ductal and stromal proliferation in males. It's very common. Neonates present 60 to 90%, adolescents 50%, and men 50 to 69, up to 70%. Causes are hormones, drugs, systemic disorders such as cirrhosis, chronic pulmonary disease or chronic renal disease, tumours, particularly estrogenic tumours, and it can be idiopathic. On mammogram, it's just seen as density deep to the nipple. It can be asymmetric, bilateral. We don't routinely perform mammograms for gynecomastia. Sometimes surgeons in Australia request mammograms, particularly if they're considering surgical excision, which is just for the patient's sake. There's no need for surgical excision. We also perform them if the patient has a strong family history of breast cancer, or that they can feel a palpable lump. They're usually evaluated with ultrasound, and as we mentioned yesterday on ultrasound, it's a retroareolar hypoechoic mass that's often flame-shaped with projections. It can be unilateral or asymmetric. And this is a case of more florid gynecomastia. You can see here there's quite a lot of tissue. This is the left and the right breast for comparison. So we're really just checking with ultrasound that there's no associated mass. This is a 54-year-old man who presented with a palpable lump. So we actually had a vaginal mammogram. You can see here that there is this suspicious area just lateral to his nipple, which we do some magnification views, and you can actually see that there is a mass containing central calcification. This is what it looked like on ultrasound. So we did a core biopsy of that, and that was biopsy proven invasive ductal carcinoma. Male breast cancer is very rare, with a lifetime risk of 1 in 1,000. The risk factors for development of male breast cancer include advancing age, hormone imbalance, radiation exposure, a family history of breast cancer, in particular the BRCA2 gene. There is no increased risk with gynecomastia, and the ultrasound and mammograms findings are the same as for female. Here's another case of a 64-year-old that presented with a palpable lump. You can see here this irregular mass. That was another biopsy proven invasive ductal carcinoma. So just a little bit about pregnancy and lactation, because I know this was covered yesterday. As we mentioned before, ultrasound is the first line of assessment, really due to the radiation dose of mammograms on sensitive breast tissue and also the density of the breast tissue. So on ultrasound, these are the images of the changes associated with pregnancy. You get lobular growth, which results in increased epigenicity of the breast parenchyma, as you can see up here. And at the end of pregnancy, you start to get tubular hypoechoic structures here, which are the colostrum fluid ducts. During lactation, most breast tissue parenchyma is epigenic due to glandular enlargement. It becomes engorged with milk-rich in fat. It's often hypervascular. You get distended ducts with mobile contents. This is very typical findings in lactation. This is one of the reasons why the lactating breast is not well assessed with mammogram. It's heterogeneously dense with a nodular appearance. There's a marked decrease in the fat tissue and it has a prominent ductal pattern. This is a breastfeeding patient who is feeding more commonly on her right side than her left, and you can see the marked asymmetry. So this is a typical lesion that's seen during breastfeeding. This is a 36-year-old female patient with breastfeeding. You can see here this is well-defined mass, 12 to 1 o'clock, that has some fat density components to it. This is the tomosynthesis images of the same region, very benign appearance. And this is the ultrasound findings. So it's got a thin hypoechoic rim, it's isoechoic centrally, it's very superficially located, and it does have a little bit of posterior shadowing. And that's the typical galactocele. It's the most common benign breast lesion in young lactating women. Mostly they develop following cessation of lactation, and it results from lactiferous duct occlusion. It's often in the subareolar region. It can be complicated by infection, resulting in a breast abscess. It usually presents as a painless breast lump occurring over weeks to months. It can be single or multiple, unilateral or bilateral. This is a different patient with galactocele, and the mammography findings depend on how much fat is within the lesion. It can be radiolucent like a lipoma, or you may even see a fat fluid level, particularly in the MLO imaging, like this one. You can see all the dependent part has settled. Another galactocele. On ultrasound, it's usually cystic or multicystic, more commonly than mixed solid and cystic or solid. It'll have no internal vascularity, and in this one you can see that fat fluid level. The next topic I'm going to talk about is lactating adenomas. They're benign tubular adenomas, typically occurring in the pericardial period, most commonly in the third trimester of pregnancy. They're usually painless, they're palpable, mobile lesions. They undergo rapid growth and may be large in size, up to 10 centimetres. They usually resolve or reduce in size in the postpartum period or with cessation of lactation, but they may recur during subsequent pregnancies. They occur in response to the physiological changes of pregnancy and during lactation, likely due to the rising estrogen levels. They have a predilection towards the anterior portion of the breast. These are two different lactating adenomas. On ultrasound, they're usually well-defined, homogeneous and hypoechoic or isoechoic. They may have posterior acoustic enhancement and contain large cystic areas representative of infarction and necrosis. A third of them are compressible. You can usually see epigenic bands coursing through the mass corresponding to the fibroid bands, which are seen on histology. They often have internal vascularity, and they are usually biopsied. So these are two quite different looking lesions. This one is quite a benign appearance, more multicystic, and this one appears more solid. These are also lactating adenomas. This one was a palpable lump, This one, as you can see, has more of a suspicious appearance. It's got some slightly irregular margins, some internal vascularity, but does have this internal cystic space. And this one here is very difficult to see. It's isocholic and smoothly marginated, having much more benign appearance. And just lastly, I'm going to talk for a few minutes about pregnancy-associated breast cancer. This is defined as breast cancer occurring during pregnancy, throughout 1 year postpartum, or during lactation. There's an increasing incidence in pregnancy-associated breast cancer due to the decreasing age of onset of breast cancer and increasing maternal age. Unfortunately, delayed diagnosis is common due to a lack of awareness of pregnancy-associated breast cancer, a fear of radiation from mammograms by patients, and also the denial of suspicious signs and symptoms. It's also that a lot of these symptoms and signs mimic other benign breast conditions. The patient may think they have mastitis. 7% of breast cancer in all women under 45 is associated with pregnancy and lactation, and it's most commonly seen 6 months postpartum. Usually the presentation is of a persistent mass with other symptoms such as skin thickening and nipple discharge. This is a 36-year-old female that was breastfeeding. You can see on the mammograms really the density of the tissue obscures any findings at all. And she did have this palpable lump, which we could see on ultrasound as hypoechoic irregular mass, tall and wide with some internal vascularity. It's very close to the skin. That is an invasive ductal carcinoma. As mentioned, ultrasound is the first line imaging modality. It usually shows up as a hypoechoic mass with some fluid component related to central necrosis or cystic degeneration. There's irregular margins and posterior shadowing. A palpable complex cystic mass during pregnancy and lactation needs tissue sampling and should not be ignored or downgraded to a galactocele abscess unless the signs and symptoms are strongly suggestive of abscess. Mammogram is like all other types of breast cancer. Sometimes you can see calcification, mass, or architectural distortion, although the sensitivity is reduced by the density of the breast tissue. As you probably already know, the radiation dose is actually quite low on a bilateral 2U standard mammogram. It's equivalent to about 7 weeks of background radiation, so if they need a mammogram, they should still that one. What you can do is get them to pump or breastfeed immediately before the mammogram, and that will reduce the parenchymal density, which is what we did in this case. This was a breastfeeding patient, 6 weeks postpartum. We got her to immediately breastfeed, and the mammograms are actually quite good. So you can see the abnormality, it's in the left breast. It's up here in this upper outer quadrant. She had a spiculated mass. You might notice on this too, there is some slight contraction of her left nipple. These are the tomosynthesis images. You can see up in here and there. There was no calcification or skin thickening in that case. And this is what it looked like on ultrasound. She had this irregular spiculated mass with surrounding hypoechoic tissue, which was also suspicious. So that was the mass we could see. That's the mass again, and that's the nipple. And this hypoechoic tissue extended all the way to the base of the nipple. That was biopsy-proven invasive ductal carcinoma. And this was her lymph node. So you can see up here, this is the actual lymph node in total. So it does have a thickened cortex, and that was the central hilum. But she actually had this hypoechoic irregular little mass projecting out of the cortex of her lymph node. And that was some extranodal extension by the tumour cells within the node. So that can be seen sometimes if you look carefully on ultrasound. This is what it looks like on histology when it actually breaks through the cortex, and that was proven when she actually had the nerves removed in surgery. And having this tumour cells perforating the lymph node capsule is actually associated with increased risk of recurrence. This is another 35-year-old. This was actually a 53mm invasive ductal carcinoma. So I think it was Mary that mentioned yesterday, sometimes when these tumours grow rapidly, they can actually have a very smooth margin rather than having the regular spiculated margin that we expect. This looked like a giant hyperadenoma or Pillodi's tumour, but it was actually invasive ductal cancer. So the take-home messages, although proliferative breast conditions are benign, there is an increased relative risk of malignancy. Again, you need to make sure that the radiological findings and pathologic findings correlate. Otherwise, you need to consider further biopsy or close follow-up, perhaps even surgical referral, particularly in cases of sclerosing adenosis and complex sclerosing lesions. Just remember that 7% of core biopsy with stromal fibrosis are upgraded to cancer with excision. Gynecomastia is common and male breast cancer is rare. Benign conditions such as galactocele and lactating adenomas are commonly seen in pregnancy. Some of them have characteristic benign features, but others require biopsy. And pregnancy-associated breast